Today, the topic of our presentation of our webinar is the techniques and interpretations of AML-MRD by flow cytometry. And we have our eminent speaker, Dr. Wang, with us, who is the chief of flow cytometry from MD Anderson, University of Texas. And Madam has a vast experience and the research in the clinical expertise on flow cytometry, and she has authored like more than 300 review articles, many chapters. A very exciting thing that she is a editor in the Clinical Cytometry B, which is the journal, it's like a Bible for us, where all the flow cytometrists go and look for our doubtful cases. And she has authored several books and the chapters, and she is the current one of the sitting members for the AML, MRD, and MDS by flow cytometry in the ELN group. And without taking much time, I'd like to welcome Dr. Wang. Ma'am, you can please start sharing your screen, and we are very excited to hear from you.
Thank you, Dr. Gupta, for introduction. As I say, I have been giving this topic. It's a little bit from the usual AML-MRD I gave to other places. So this is the one asked me to talk about some technical interpretation of AML-MRD by flow cytometry, and asked me to do some case-based discussion with the practical nuances. So, as you know, I work at the MD Anderson. We do actually a lot of AML-MRD, for flow cytometry, and of course, there's molecular genetic testing, with the samples. We just summarize, in 3 months, consecutive months, when we just implemented 12-color AML-MRD. For patient, we have more than 379 patients achieve morphologic remission in 3 months period. So we just summarize that data. I think it was actually quite interesting for people who interested in, flow cytometry implementation in your laboratory. So I want to start very, very straightforward. First, markers. So, right. So what are markers to use? So the EON, the first, recommendation, published in 2018. So only 8 markers using 8-color flow cytometer. You can see just very, very basic markers. So this is, in my opinion, it's not sufficient, right? So, you don't have good markers for monocytic leukemia. You don't have, some of them, you don't even have CD38 in here. Right, but that has been, if you use a huge number of cases, you're going to see some significance. The EON usually use the leukemia-associated immunophenotype. That's majority of them cases they use that. So this is the second, this is coming up recommendations, right? So this is Freeman present, last year at the ICCS meeting. So the core markers now, finally, like CD38 is getting into the place, but they still recommend CD11B, which we don't really use. It's only in about 5% AML. So they did recommend monocytic markers. I'm kind of a little bit surprised, and CU123 is in the monocytic markers. So CU123 is super useful, not only in monocytic, leukemia, and also in the primitive immunophenotype, which is CD34-117 positive and CD34 negative 117 positive ones. So then there's leukemia stem cell markers. This will be the new recommendation. The instrument will recommend about 10-color or above, instrument, right? So this other recommendation, this is what we use. So we published these panels on cytometry B, for the validation. If you read that paper, our panel actually got FDA, IDE clearance, because we've been asked by our clinicians to send this for FDA IDE approval, because it's they use the MRD to enroll patients. As you know, there's a lot of therapy have been targeting, MRD. If you use MRD as enrollment criteria, it's considered to be high-risk assay. We need to get an FDA clearance. So this is the 12 color, we use LAIP, so if you see here, there's a lot of markers are repeat, in both tubes. So CD45, CD38, we have CD34, and we have, CD117. So these 4 markers are essential, it's our backbone markers. And then the markers, recommended by EON, we have C3313, we have HADR, and then in addition, we have 123, have been built in this panel. So 123 we have used, since we use 8 colors back to 2012, right? So it's very useful marker. So then we also, in this new panel, we did replace, the C71 with C36, because that's actually the only markers for erythroid and macrocytic, in this screening panel. If there are more, we're going to add more the markers, but the list has 1 marker cover erythroid macrocytic. So, there's a couple markers you may not know very well. One is CD133 and CD54. And the CD25. I'm going to show you a little bit, the significance. CD133 was, actually in the first time they recommended other optional markers. So CD133 we found is quite useful in the bone marrows. Actually, only the CD34 cells, the red cells, are positive for CD133. And among the CD34 positive cells, only positive in precursor coming to the myeloid. This is very important, because among the CD34, there's a lot of other cells, right? So only the one committed to the myeloid will be positive. So how will you use this marker in AMMRD? So first of all, when the CD34 disappear, they should disappear. If you see your cells CD34 negative, but 133 positive, that's aberrant. So vice versa, if you see your C13 positive or 34 positive cells, absent of 133, then that's also aberrant. So it's a pretty good marker, but however, you really have to know what combination you're looking at. So, and also actually the aberrancy frequency is not that terribly high. I'm going to show you, how frequent you observe this aberrancy. CD54 in the normal bone marrows, monocytes are definitely positive. In the normal precursors, this is also considered as a stem cell markers. So in the very reactive, the early precursor cells usually has a flare, not very strong. But in the abnormal, the C34 cells, you can see this is normal myeloid precursors, this is abnormal, and this is all abnormal, right? And also it's very useful for the monocytic leukemia recently found. So this is the CD25. CD25 is also considered as a stem cell markers. So again, in the normal, this is GCSF, right as GCSF, you can get a little flare, increased expression. But in the abnormal, again, if you now know why the CD38 is so important, you actually look at a lot of markers against CD38 to look for aberrancies, right? So C25 is also very important to look for aberrant mast cells. So for example, like we get on CD117, strongly positive, DR, dim positive, these are the mast cells. They're here, right? They're negative for CD25. So this is actually a patient with inversion 16. Not only we identify aberrant blasts, we also identify aberrant mast cells, like a CD25 expression. So we recently found the mast cells also, except that this aberrant marker expression, sometimes, they express very high 123 and the CD38, actually also indicative of, a neoplastic process. So that, we're kind of still summarizing the data. So in AML MRD detection, you're already seeing this, and I'm not going to, to say anything very different. You do need both. I know EON very heavily count on leukemia-associated immunophenotype, but however, this is very important approach. I can show you with this very simple cartoon, to show you why this is very important, right? So, like a normal precursor cells. So, in AML in elderly, it's accumulation of molecular genetic events. So, first of all, they have 1 or 2 mutations, which we call pre-leukemic or MDS clone. So after that, they keep, accumulating, and also they have some drivers, like make the cell proliferate, immature cells, so you become AML. So this is the immunophenotype at the time of AML detection. So at the MRD or relapse, you can have the identical clone. So you also can have clonal evolution. You get more abnormality. There's no problem to detect this, right, usually. But sometimes you do have clonal regression. You lose some markers, like when you see at the time of diagnosis. And then sometimes you do have clonal evolution and a regression at the same time. So you lose one and you gain another one. It looks very different from the original leukemia. And another thing is most common is a subclone selection. At the time of diagnosis, this clone is super small. You don't see them. But however, they they are really treatment resistant. At the time of MRD, you see very, very different immunophenotype at this. So that's why, leukemia, deviation from normal is absolutely needed. But however, you have to be very careful. So which it is, they actually reverse back to the pre-leukemic cells or MDS clone, right? So, then they do look different from this, AML blasts. But however, I'm going to have some one case to show why this is very important to recognize, because these patients should not be continually be treated as residual AML blasts, because they cannot tolerate a treatment, a toxicity, and also does not really provide a lot of benefit for the patients. So then so the next question, the technical, right? So we focus on a lot of technical issues, where to look for or find AML MRD, right? So because, for BALL, we gate on the CD19, and from CD19, then we look for, MRD. But in AML MRD, where you look for blasts? So we commonly say the CD45 dim gate is the so-called blast gate. But however, there are a lot of cells in this area. I will show you what the cells are. Then the second one is the CD34 myeloid precursors. So actually, majority of the AML-MRD, recently, as I say, we summarized data, 80% cases you actually identified, more than 80% in this compartment, the MRD. So then the CD117 positive cells. So it is very important for the CD117 positive, CD34 negative AML, because some of the cells, the leukemia, the stem cells, actually they are CD34 negative. Then you find them, the immature cells, usually in this compartment. But however, there are a lot of cells are positive for 117. We'll have to know what cells are positive for 117. The monocytes, of course, it's very important for patients with monocytic leukemia. And I'm going to have, and also have, like an emergence of monocytic relapse from the patients who are not monocytic leukemia, right? I'm going to have some examples to show that. So this is a CD45 dim gate. We can easily count 10 different cell populations which are not blasts in this area. So of course, you have myeloid precursors, you have stage 1 hematogons. These are all CD34 positive. So you have stage 2 hematogons. You have some immature monocytes in this area, and some immature granulocytes in this area, and the erythroid precursors, and the plasmacytoid dendritic cells, and also basophils. They are in this CD45 dim gate, right? So this gate, when you use this gate, you really have to know, what are the immunophenotype of all the cells. And also when you look at a lot of cells, you lose your sensitivity. So the bottom line is you do need to look at CD45 dim gate, but however, it's by itself, it's not sufficient, right? So because you lose your sensitivity, and you have to interpret a lot of other normal cell counterpart. So then we talk about the CD34 myeloid precursors. So, as I was saying, more than 80% AML-MRD you identify in this gate. First we actually exclude the hematogons. If we confirm they are hematogons, they are not just like a variant 19 expression. Variant 19 will come from here, right? So then we actually exclude them from analysis. But even the CD34 in normal bone marrows, they show very diverse populations. So these are all CD34 positive cells. But as you know, you have here plasmacytoid dendritic cell precursors. You even have a little bit probably monocytic precursor or plasmacytoid basophil precursors. So you have a lot of erythroid precursors. Erythroid precursors are CD34 positive and CD117 positive, HADR positive. You really can, a lot of times you cannot differentiate from the myeloid precursors. But however they do, they have some features. They are 123 negative, 133 negative. Remember, 133 is only commit to the myeloid, and they usually do not have CD13. Right. So these are the important things to remember. What are you looking at in the normal CD34? It's not just one population. They show diverse differentiation. So we also incorporate fluorescence intensity, to evaluate aberrancy. Not only looking at the patterns, but we also looked at MFI right on the plots. We actually insert token. So if you see this is the normal CD34 cells, and this is abnormal. Not only you see the pattern, there's alteration, but also when you look, the MFI, for example, the C13 is already to the 7,000, and this C13 is about 18. Our normal range is less than 3,000, right? So same with HADR and the CD123. So important markers, we not only looking at the patterns, but we also provide a MFI, for evaluation. For the CD45, if you see this is a normal myeloid precursors, just right under the granulocytes, but this one is, complete shift to the left. That means 45 is decreased, right? So, so why we need to do that? Why not just say aberrant lymphoid antigen? Because aberrant lymphoid antigen only pick a subset of AMMRD. I wish every case has very strong lymphoid antigen expression, but that's not really the case. But even lymphoid antigen, right? So you have to know, actually, like a normal myeloid precursor can express the CD2, CD22. That's why we removed this 2 from the AMMRD. This actually can be seen in stage 0 hemaggone or so-called common lymphoprogenitors, early plasmacytoid dendritic cells. Even the CD7 and the CD56 can be seen in regenerating, myeloid precursors, right? Or the erythroid precursors so they usually partial CD7. So to evaluate the lymphoid antigens, how do you know it's not reactive? How do you know it's true expression? That's very important to look versus other combination markers. This is, I just made these figures for our next publication. So this is the regenerating CD56. So they are on the CD38 very bright population. So they are, like CD34 is scattered, and this is the true, like MRD, and they're on the CD38 dimer population. Same for CD7, like the reactive usually on the very bright CD38, and they're on the CD13 negative ones. Remember that erythroid precursors, plasmacytoid dendritic cells, they don't have CD13 expression, right? So this is very important. If you see this is abnormal one, they're on the CD13 positive. So this is on the dimmer CD38. So, even for lymphoid antigen, you have to look the verse, like other markers, CD38 or CD13. So, and also the reagent, it's quite important. This is the one commonly used, by a lot of people, CD56 and Chem1. So, if you see this is reactive, and this is neoplastic, like a C56. So this is a, same case, we use another clone. You actually, sometimes you still see a little bit, but a much less reactive CD56. So the neoplastic one, you're still able to detect them, right? So this is important to choosing, good reagents, to avoid non-specific, the reaction in the reactive cases. So, and also to understand this, the CD38, we keep saying you have to look at all the markers with CD38. But the premises is like you have to understand, what is exuberant in early myeloid precursors, how they look like. It's always to tell from the reactive, right? Especially this, you see a lot in the 21 days bone marrow, they gave GCSF with a high dose chemotherapy. So this is a very exuberant reactive case. So you have this black cells as early stem cells. So they usually have the very bright C34, low C38, and also they kind of give you a little bit look like a barren C33 and C13 patterns. So but then the other markers are very consistent. 133 is not increased. CD4 is higher. And then every other marker usually is kind of lower. 54 is a little bit higher, 25 is a little bit higher. So this is the early regenerating. We actually put the immunophenotype on every PDF on every patient. Always remind the pathologists, are you dealing with the early regenerating, right? So if it's not early regenerating, then will be considered as altered, if they don't follow this pattern. So this is the one case is, very similar to the early regenerating cells, but however, you look at C30A, you have no problem to point out this is the abnormal population of blasts, right? So looking, versus C30A is very, very useful. Right, so this is another AMMRD positive case, you have a lot of regenerating cells, the normal precursors, but then you have this is not difficult because the C7 positive, again, it's on the C13 positive cells. So they're on the C38, lower ones. And the 54 is also increased, the C33 decrease, and the C117 is not high. And then 123 is increased. So that's so this is in a regenerating, you identify the residual blasts. So these are the markers, what do we count on as altered expression, right? So as we say, if you only count on the CD7 and the 56, you only detect about a little over 50% AML cases, but the rest of them you really have to count on the some level change, or sometimes you can lose or gain one antigen. So this is the one we summarize, 357 cases. So this, this is the positive case. You can see what are the very frequently changed immunophenotype, right? So this is, we have to count on the other markers. So one thing is, to at least to increase your confidence level if you see more aberrancies. So now I'm going to go over some cases, so then we said AMRDs remain to be challenging, but the challenge can be solved with solutions. So first of all, first challenge to us is when the immunophenotypes are completely different from the original leukemia, how you determine if this residual leukemia with subclone selection or phenotypic switch or reverse back to previous MDS or persistent clonal hematopoiesis, right? So this is the case at the time of diagnosis, very abnormal. If you see the C33, C13, one blob, and also has CD7 expression and a little bit of 56, not much, and also most of them have no HADR. So, when you get a case like this, I say, oh, yeah, the AMMRD will be very easy, right? So, but now, after the patient been treated with actually, small molecule inhibitor, after 3 months, we have actually the cells, looks like almost complete normal pattern. Is we say the banana shaped, C13 and C33. But however, majority are normal, but we did see some CD7 positive cells, and it's on the C38 dim population. So if you see here, looks like they all 56 positive, and also they still have this, pattern 123 high and a DR low. So it looks like this is actually selected, as we say, subclone selection. So this turned out to be the most resistant ones, the 56 positive, and then they survived, and then in the AMMRD, right? So this is another case, a very little CD7, but a strong 56. And, you can see this is the one with AML with plasma cytodendritic cell differentiation. It was a very bright, 123. So a little bit of 5. And at time of detection, again, you see this one with aberrant lymphoid antigen tend to survive. So this is no problem. This is subclone selection. You just call it a positive, and then it is consistent with residual AML, right? But it looks like it just selected a subclone from here. But now we move to another type of another situation, then we have to decide what are this, are the subclone or something else. So this is at the time of diagnosis, the patient was NPM1 and IDH1 mutated. So you can see this is the typical APL-like immunophenotype with 117, no C34, no HADR, increase 123. So then there is, like a C13, C33 pattern look like this. This is very typical, right? NPM1 APL-like immunophenotype. At the time of AMMRD, like if you see here, looks like very few immature cells. And then now, we really don't have the cells, similar to the original immunophenotype, right? So most of the cells look like myeloid precursors in here, and the monocytes, we usually include monocytes for analysis. So the AMMRD turned out to be negative, but however, if we look at CD34 cells, so the CD117 is definitely elevated, and the HLDR is decreased, and also 45 is decreased. So, this is, if you don't remember what normal is supposed to look like, so this is the normal 117 is low, and the DR is high, and then this, the C34 cells, you just right under the granular sites, right? We do see these alterations, this abnormality of the C34 positive cells. So are this residual leukemic cells? So, I know a lot of places actually, when they do this, they just say possible aberrant myeloblasts. That's it, don't provide additional interpretation. So the patient came back, of course, is NPM1 negative, but IDH1 remained to be positive. So we actually decide to study, this phenomenon. So we pull out all the NPM1 AML. At the time, we have the 75 cases, so at the time of diagnosis, every NPM1 had co-mutations. When the patient achieved the CR, we still have 73% patient has persistent clonal hematopoiesis. That's by NGS, they still have mutations. So around these patients, the residual patients, and almost half of them showed this abnormal immunophenotype by flow cytometry, which we call the pre-leukemic cell immunophenotype. So, if you see this pre-leukemic cell immunophenotype, they tend to correlate with certain mutations like IDH2 and SRSF2. So they tend to have a higher VAF, the one with, flow abnormality, compared to one without the flow cytometry abnormality. But the important thing is, they actually really don't affect relapse-free survival. So, recently we summarized another, out of the NPM1 setting, we showed a similar phenomenon, very common with IDH2 and SRSF2 mutations, high VAF, and also does not affect leukemia-free survival, but it did affect the overall survival. So we think, these patients with the PL immunophenotype, they probably had high-risk clonal hematopoiesis or low-grade MDS in the background of these patients, right? But, for clinicians, very important, don't continue to treat. Pathology need to report these are not AMMRD, they're aberrant, but we favor this to be pre-leukemic cells, right? So it's very important not to continue to treat the patient with residual AML. So, we actually also summarize in several papers, to show what are actually the immunophenotype for pre-leukemic cells. They're usually less than 1%. They're almost CD34 positive. So they don't involve, CD7 or CD56. They don't completely lose one antigen or gain one antigen. Usually it's the level change, expression level change, right? So the thing is, don't call, them AML. That's very important. Now we talk about challenge number 2, so as Venetoclax treatment regimen, and now it's widely used for AML patients. but then also affect the AML relapse. I'm going to show 2 examples. So this is a 53-year-old patient with, KMT2A rearrangement, and NGS also showed KRAS and RAS mutations. So this is at the time of diagnosis, predominantly monocytic. Actually, even the monocytic, you have 3 different populations. Intro population heterogeneity is common. It's, as I say, it's mostly, monocytic, and also with a subset with, dim CD14 expression, right? They are, the blue cells, if you see here, they're all monocytic. So, like now we talk about the monocytic leukemia. Everyone is asking, so how you detect monocytic leukemia, right? So, monocytes first understand what is the normal immunophenotype for normal monocytes. So these are the immunophenotype. So what considered to be immature? If you don't do, the other marker like 303, those fancy markers. So in your common, panels, what do you see? So this is how we summarize, if they have very significant decrease of CD or negative C13, decrease C14, and decrease and a negative for C36, and also 54, increase CD15 and 123. So, this marker, like if you see a lot of them, they actually consistent with immaturity. So, but however, this is not a vice versa situation. What does it mean? If you see complete mature immunophenotype, does not mean your cells, your monocytes are mature, right? So this is very important to remember. So before, we always educate our faculties before venetoclax treatment. We say, if we follow monocytes, it's not reliable because there's a lot of overlapping between neoplastic versus reactive regenerative monocytes. So the real remission bone marrow should contain normal CD34 cells, unless the patient's early relapse from stem cell transplant, because you still retain a lot of CD34 cells. And then, if you have abnormal CD34, it's very likely you probably have residual AML. So, but if you don't see any CD34 cells, you actually better to look very hard, in the monocyte region, you may identify residual AML. So that's actually the basic principle in patient not treated with venetoclax. But after venetoclax treatment, this have changed a little bit. So, we back to our patient. So the patient, of course, treated with inclacibine, cytarabine, and plus venetoclax, and then achieve morphological remission. And the patient continue being treated. So this patient, like we show the monocyte at the time of diagnosis, we did not show the CD34 cells. So if you see CD34 cells as very abnormal, right? Very low CD38 and abnormal CD33-13. And then they have, CD133, no CD4, and the 123 is increased, DR is decreased. So now this is time when we check the MRD after this treatment regimen. The CD34 cells looks completely normal. So this is the normal pattern, very bright 138, and the normal pattern banana shaped, and also the normal pattern, the erythroid precursors. And then we have some, like a diverse differentiation. CD34 cells, no surprising. Then we looked at, the monocytes. So remember, this is at the time of diagnosis to compare. So it looks like, even monocyte looks very normal, like the pattern looks very normal, has good CD4 expression, had, no 117, no CD34, right? But however, you just have to continue to look at the monocytes. So when we look at the monocyte, the CD14, so the black population is negative. So then they also have increased CD123. This is normal monocytes, abnormal monocytes. So increased CD15. Remember, I just told you what are indicated on immaturity, decrease 14, increase 123, increase CD15, and also decrease 54. So this case of 4 was actually pretty much okay, and they still have CD36. Right. So this population actually turned out to be the monocytic leukemia and 2.3% of the total events. So this is, why you see this phenomenon. So why, the patient, like a monocyte, you have a recovery of the normal CD34 positive cells, but why the monocyte to be abnormal? So remember the venetoclax is BCL2 inhibitor, right? So, but however, monocytic leukemia preferentially relied on, MCL1 for apoptosis, not the BCL2. The monocytic leukemia tend to be more resistant to venetoclax containing treatment. So so this is the more into this paper, but I think the figures probably illustrate more. So for patients, we say the primitive immunophenotype and the monocytes, at the time of diagnosis. So if the precursor cells, it's myeloid primitive immunophenotype, even though they have monocytes and the primitive cells mean CD34 positive. So they are all, if the leukemic stem cells are primitive type, they depend on BCL2, you easily achieve complete remission, right? But however, if you have like two types of leukemic stem cells, one for the primitive one for the monocytes, doesn't matter at the time how few monocytes you have. So at the time of the treatment, it's the monocytic cells tend to survive. Right? So if you have like a two type of different leukemic stem cells, so that's what you get. You get monocytic relapse or the residual monocytic leukemia. So if you only have the monocytic leukemic stem cells, so like at the time of diagnosis, of course, you have the monocytic relapse. Another further, they illustrate actually this monocytic relapse, a lot coming from the cells with NRAS and KRAS mutation. So at the time you have significant population of monocytes, you have monocytic relapse and still containing the NRAS. So even if you have very small number of monocytes at time diagnosis, so if this case has a KRAS, at the time of the relapse, you actually have significant expansion of this, like a KRAS containing cells. So this explains to you why monocyte leukemia becomes quite important to monitor, in patients at the time of diagnosis, whether it's monocytic or not monocytic. Take a look of your monocytes, right? And this also applied to the erythroid leukemia and macrocytic leukemia, because remember the erythroid macrocytic differentiation, they also don't really, depend on the BCL2, like a apoptotic pathway. They, mostly depend preferentially use BCL-XL, for apoptosis. So these are just a different mutation profile. I'm going to show you one actual case. So the patient had a therapy-related AML, secondary breast ovarian cancer, and with a biallelic TP53 mutation, complex karyotype. At the time of diagnosis, it was actually typical CD34, CD117, DR3313 positive myeloid phenotype. Then the patient actually also treated with, venetoclax containing, regimen. So when we look this, at the AMMRD, we have very few cells, in the 45 dim area. So if you see, this a few monocytes, mostly actually granulocytes, right? So this gray cells are granulocytes. So if you look at the CD34 positive cells, so we do have a huge population, the purple cells commit to the erythroid. So they don't have 123. We have myeloblasts, then we have erythroid precursors. The erythroid precursors are very, they do have CD4, but they, like their myeloid precursor, they also have CD7. So they don't have CD13 and they don't have CD123, right? The myeloid precursor has actually 56. So we also have another gate that means another thing important is looking at the CD117 gate, because if you want to look erythroid, we usually look at the immature ones. We gate on all the CD117 positive cells, including high scatter. So for the CD117 positive cell, you can see all the way going to, we think they are granulocytes. And it turned out to be they're actually really not granulocytes. They are the, containing the immature erythroid precursor with a lot of aberrancy, 3313, and they have 54. They have CD36 erythroid markers, and they have, like the CD71 and the, glycophorin. So these are the immature erythroid. Every case we have morphology, then you start to see this very immature erythroid, almost blast-like, pronormal blast, but the very abnormal ones. If you look at biopsy, you start to see these cells, right? So this case, even though we only have 1 to 2% of blasts, we did have 10% of pronormal blasts by counting. So, like we wait, so this is the PAS to show you this abnormal erythroid precursors. So, we wait a little bit, like the next biopsy just showed acute erythroid leukemia. So this patient is very typical, in patient with TP53 mutation, then you have the erythroid relapse. Even it's not erythroid leukemia, but a lot of cases we see increased abnormal pronormal blasts, but because they're really resistant to chemotherapy. So this is the case to show you the challenges, in the era of venetoclax containing treatment. You have to open your eyes to look at all the populations, not just the CD34 cells. So I think I still have, I'll spend maybe another 5 minutes to talk about the last case. Then we can have some time for discussion. So challenge number 3, and this is, AML-induced differentiation. We know now we have a lot of chemotherapy, AML treatment can induce differentiation, right? So this patient is therapy-related with KMT2A rearrangement. So the patient as induction chemotherapy, but the primary refractory still have 77% blasts. So after then 2 cycles, venetoclax, and the patient still showed persistent disease. So this time, then they gave the Menin inhibitor, therapy, So this is a pre-Menin inhibitor, this is monocytic leukemia. Of course, it's KMT2A. That's why, you tend to see monocytic leukemia. So you see, this blue cells. So they have CD4, very few CD117, small subset. And then they have significant loss of CD14 and also almost no HADR expression. Very high 15, remember, what do we say, corresponding to immaturity, and also increased CD123, right? The monocytes are very abnormal. But the post-Menin inhibitor, then the patient achieved morphological remission with less than 5% of blasts. So you can see here, it's very different. The monocytes are now coming here. We have a lot of granulocytes. Before we have almost no granulocytes. And the monocytes looks, like a very mature, if you see C64, CD14, it's completely expressed. Now they all have HADR. So the 15 is decreased, right? So, this is granulocytes in the background, and the 123 is also decreased. We have some plasmacyte dendritic cells or non-classic monos with a little bit high 123 as internal control. The monocytes look like a very well behaved, looks like a very normal. But however, if you look at immature cells, this is the CD117, the pre-Menin inhibitor, is 1.08%. So they predominantly CD117 positive, very few CD34. So they also have no HADR. And a very bright CD123, and also very low CD38, right? So at the time we see the morphological remission, and also patient, the monocyte look completely normal. We still have the cells, but somehow it shifted more CD34 positive. But they still have increased 123, no HADR, and they also have low CD38. Right. So, from this immature cells, we know this patient still have residual disease. But however, the question is, how many the patient have residual blasts, residual leukemia? It's a 0.13%. This case, we actually did a FISH, we showed 31% cells still have, this KMT2A. So that's understandable because Menin-induced differentiation, right? So, they are in mature granulocytes, you still detect the signals. So don't get discouraged, say why, it's not consistent with my flow findings. Because of flow, we report immature cells. So I think, when you count, you also count immature cells. So I think, in patients treated with, a differentiation inducing agents, we still have to use the immature cell report as leukemic, like a residual leukemia. So the patient continued treated with Menin inhibitor, then after cycle 4, actual disease, start to have morphological relapse. So, this is the one at the cycle 4, we see more this immature cells. So this is the one, this is a typical what we saw before in monocytic leukemia, before venetoclax treatment. It is the immature cells tend to be the residual leukemic cells. And so because, understandable, because monocytes derive from the immature cells. When you have residual leukemia, they tend to stay in the more, immature cell compartment. Right? So this is, to summarize, drug-induced differentiation, maturation. So what cell population to check and the report. So we still focus on, the answer is we still focus on the immature cells. And do mature cells, whether do mature cells have leukemic potential? I think that's a very good question. We kind of tend to think, they probably cannot divide or they cannot, they don't have the leukemic potential, but I think it's not entirely clear. I think I'm going to stop here, then give you some time to ask questions.
Thank you, Dr. Wang, for such a lucid and so many interesting cases you have shown on AML-MRD, yet a very complex topic and so many patterns to see and follow. So, in fact, we also, we have adopted from your panel only 12 color lyric panel for AML-MRD with certain changes, but this 133, 54, they seem to, we are not using 54 and 133, but they seem to be very helpful as I have seen today in your talk. But most of our panel with the fluorochrome combinations we have adopted from your paper on AML-MRD only. So now the house is open for the questions.
Yeah, I have to say, I actually think CD5 is not essential because we summarize very few, less than 2% cases with possible CD5. We kept the CD5 because, we use the same panel for our acute leukemia at the diagnosis. Because at the time of diagnosis, you also may be dealing with, TALL, other cases. So that's why we kept that. So I actually recommend people who want to adopt this, maybe you can change it to CD11B, but I do think 54 and 133 are very, very useful, especially 54, now more 54 is also positive in, NK cells and plasma cells, sometimes in the 45 dim gate actually really help you, for that too.
Okay. So, okay, so we have a question by Dr. Pratyush that please suggest the best antibodies in your experience which can be used to differentiate 34 positive and 38 negative, again, hematopoietic stem cells versus leukemic stem cells. In the starting, you showed that what is the coming proposed antibody panel which is coming. So what is your experience on the same, ma'am?
So you mean to tell the leukemic stem cells versus the normal precursors?
Yes.
Yeah, so, we don't, I have to say, we don't really do the leukemic stem cells, but we do have a couple markers as the leukemic, so-called leukemic stem cell. 123 is one, 54 is one, 25 is another one. So I think the normal, as I said, I show here, the normal, like a stem cells, they really follow the very consistent pattern. So once you recognize this, then the other things, it's never, I never seen a case actually, I did try, during the development, I did try the leukemic stem cells. This has never been, black and white. I tell you, the CLL1 is in myeloid precursor, normal regenerative myeloid precursors, right? So I think from the things I see people, they found the 45RA, it is kind of helpful. I think, from what I saw, I think it's useful. And as I said, 123 is never been black-white. 123 is in normal precursors, early stem cells. So, like but I think what CLL1, it's because it's, target marker. So that's why some like leukemic stem cells, they kind of tend to use this. But as I say, like this never been black-white. To me, but C19, of course, absolutely you should not see it. That's for sure.
Okay. Basically, so usually we have a very small stem cell population, and as you have told that it is very difficult to follow the patterns in them. That is the problem to differentiate leukemic stem cells and hematopoietic stem cells, right? It's on basis of these you have shown very clear patterns, but every time this kind of a pattern is difficult to follow.
So yeah, so as I say, if you see a C33 and a 13, altered, you have to go back to C33 versus C13 and C33. So if then they look like this, you're okay, probably. So they actually, the immunophenotype is very consistent, no matter what. Like we sometimes we also do MDS, use a very similar panel. So in patients with metastatic carcinoma, some because cytopenia suspicious for MDS, then we saw exclusively all these early stem cells. Looks very scary, but however, again, they follow exactly the same pattern. So should not confuse you. This is the one, like when you see this, complete isolated from here, they don't follow the pattern. That's the time you really suspect, just it's not normal.
Okay. So what is the minimum number of normal marrows will you recommend, to see the normal regenerative or the normal patterns? What is the number which we can follow when we are starting or establishing a panel?
Yeah, I have to say the normal is very consistent, so I think people, invalidation, people say you do 20 to 30 normal bone marrows, right? So, like, when we submit to FDA, FDA say, no, not normal bone marrow. You have to use AML negative bone marrows, just like, because the patient underwent the same, very similar treatment with regenerative changes, reactive changes, they don't want you to use the lymphoma staging bone marrow. So that's why, use the negative bone marrow, I think 20 to 30 cases probably it's good to give you good sense, what are the normal patterns.
Okay. And what about the denominator which will be used for MRD assessment, like 45 positive population or the non-debris cellular events? What does the consensus say we should use? Because like for BMRD, we use non-debris cellular events. For AML, is it CD45 positive for all? Because then we'll be excluding the erythroid cells.
Right. So the EON recommendation is the CD45 positive cells. But however, at the MD we so-called nuclear cells, after excluding the RBC, unlike RBC, platelets, then junks, we just save most of them. So because, like we have morphology on every case, you want your flow use the same denominator as when you count your aspirate smears. So we so-called nucleated, like cells. Yeah, if you see here, we call nuclear cells.
Okay, so you use the nucleated cells because yes, in ELN I read that it is CD45 positive as the denominator.
Right. Yeah.
Okay, and what are the common mimickers for the abnormal myeloblast? Do we have any mimickers like when we increase the number of events for acquisition in AML MRD? Do we get any mimickers that can mimic the abnormal myeloid blast?
Oh yeah, so these are all can be mimickers, even the NK cells, like they are in the 45 dim area, like they have 117, they can have 117, they can have 56. So, like, so that's why I say, to understand what's in here, it's very important, even within the CD34 gate, you have a lot of other cells. For example, if you see here, oh, how come it does not have 123? So you have to recognize these are actually illusory precursors. So I think actually the normal, you'll be surprised, it's actually the easiest one to sign out, because they kind of, once you get used to, you don't need to look at all the plots, only some, like focal plots, they look, pretty consistent, those patterns. So I think one thing, we kind of initially struggle was the 21 days bone marrow. 21 days bone marrow has a lot, reactive changes, regenerative changes. For example, we say, you should not see, very bright C13, but sometimes you do see, bright C13 in the 21 days bone marrow. They are kind of increased because those patients, you also, a lot of times you give GCSF as well. So, but after we learn, like pull out the 21 days, analyze and see what are the features, and then we start to educate the faculties, then we're okay. Now we're mostly okay. And also for 21 days, it's very important to compare with leukemia-associated immunophenotype to the pre-treatment, because if if there's anything, they don't really change that quickly, to LAIP. So we have, I can tell you, we have 18 people, at the MD Anderson signing out the AMRD, 18 hematopathologists. So, like you have to make your panels, learnable. You can teach people and the people can follow. So that's why we incorporate some MFI. We have the guide, the guidance, on the old, every PDF is built in the panel. So when you generate a report, the PDF, it's going to be there to remind you, what are you looking at. So I think actually, we do the QA for this reports. 10% cases will be QA. So actually we're doing pretty well. Like people really can learn. If you make it more, like a standardized.
Yes. So CD56 expression is also one of the regenerative markers. Only CD56 expression seen on blast. Can it be a feature of regenerative, this thing like heterogeneous? Here it is a small population, but if it is a heterogeneous, but 38 normal, 34 positive cells, can this also be a feature of regenerative? Because recently we had 2-3 cases, and the only finding was the abnormal, which we could call, was 56 expression that was heterogeneous, not clear cluster or 56,
Right.
but yes, it was heterogeneous. So we accounted it for a regenerative kind of a picture, but what is your experience for that?
Right, it's definitely, you can see, this is the case, this is regenerating, like 56. Again, they're on the C30A, very bright cell population, and the C34 usually is kind of very scattered, and also a lot of them on the lower end. I don't know exactly what the cells are, but it could be more towards the monocytic differentiation or something. But this is the normal regenerating case.
Okay. Recently, we had a very interesting case, Dr. Wang. So a patient of translocation 821 AML, treated with transplant, 7+3 high DAC, then transplanted. And now day 60 AML MRD has come. And this time we are finding that the PCR for translocation 821, it has, for day 30, it was 70 copies. And now it has increased to like 26,000 some copies. But the blasts are perfectly following the maturation pattern with no cross antigen expression. The interesting thing which I found this time was that the mast cells were prominent, and this mast cells, we don't have 25 in the regular panel, but then these mast cells, because they were expressing some DR and some DIM34, so I had put CD2 and 25 on to look for those mast cells abnormality. So these mast cells are expressing CD2 and 25 also. We went back and looked at the diagnostic flow. At that time, we could not identify, it's hardly 0.1% mast cells, which were not evaluated further for being abnormal. And even in morphology, there were around 2 to 3% mast cells, which was spindle shaped, but was not evaluated in terms of mastocytosis. And the diagnostic NGS, when we pulled out, it had KIT mutation, which was D816V mutation. So the myeloid blast showing normal pattern, but translocation 821 and D816V persisting to 1%. Can it be a systemic mastocytosis with an underlying AML where the the mutations are actually persisting in the abnormal mast cells, and the myeloid blasts are still, they are not there. The abnormal myeloid blasts are not there. So we are actually confused about what to do for this case in terms of treatment. We plan to put him on TKI inhibitors in view of D816 mutation, but we are confused about whether to call it as AML MRD positive or negative.
I think to answer your question, I think it is proper relapse. You know why I say that? Because AML with A21 is actually hard as AML-MRD to detect because they follow the normal maturation pattern. And also the CD19, they're gone, like even in the true residual, they disappear very quickly, even in the residual leukemia, obvious it's, they disappear. But if your case had a 56, they usually stay. The 56 usually stay. But if you don't have 56, you actually stuck. They have very few aberrancies, the blasts. So yeah, the mast cells, mast cells definitely, we found it's quite useful in A21 because a lot of them, even in immersion 16, a lot of times you have aberrant mast cells. So it actually really help you. I think one thing you have to be more careful about mast cell is, they tend to go away slowly. Like in patients, actually, when you don't have, aberrant blasts, after induction, you still see some abnormal mast cells. So that's another thing. But in your case, post-transplant, if the mast cell coming back, it's very likely it is relapse. So if it disappear and coming back, it's definitely a relapse. We haven't seen, and also A21, recently we saw a case again, looks like very normal, but then we actually saw some abnormality use 133, because, that blast is completely no CD133. That's the only abnormality we saw in that case. So that's why I think it tend to, if you use more markers, probably you can pick up some aberrancy. So that's my interpretation. Yeah.
Okay. So we have another question that if we have some basophilic precursors in post-cycle 1 of AZA when in AML-MRD, which were present at the point of diagnosis, should we be careful about them while we are reporting the MRD? Basically, basophilic precursors at the time of...
Yeah, so yeah, I think the question is how you define basophilic precursors, right? So basophils, when they activated, they can express CD117, but does that make them to be precursor, right? So we don't know, because we have the morphology, we look at morphology, they actually look like basophils, even the one with 117 expression. So we also recently published, the AML with mast cell differentiation. And at the same time, we also see AML with basophil differentiation. So, but however, I think to differentiate, basophil mature versus immature can be difficult by flow cytometry. So, and also, as you know, basophil tend to be more prominent after hypomethylation agent treatment. You can see more, those patients. I would be more careful. If you don't see aberrant blast, just see some basophils. I will not.
And just one last question, that what will be the number of events, minimum number of events forming the cluster that will give you the confidence of, at least for me, that will give me the confidence of calling them as if they're, abnormal, like LOD, LOQ, I'm asking in a nutshell. So what will be that number, that magic number where that more than this will be abnormal? Yeah, you're
right.
confident on calling that as abnormal.
That's actually a very good question. What do you all consider as adequacy or inadequacy? Yesterday we had a lot of discussion within the EON group. So for us, we actually count sample adequacy or not adequate. It's like of course, sample adequacy is more applied to the negative case, right? So the positive you can call on a poor quality sample. So, but the bottom line is, I think your question is how many events you want to see in order to call, to be positive. So I think for example, if you have 20 cell events, you can see consistently show in 2 tubes and with multiple markers. I will call it. I have no problem to call. It may affect your ability to quantify the blasts, but however, qualitative the blast was normal, abnormal, I think it's sufficient. So, but I think the sample quality for a negative case, we like to see at least 200 cells in the immature cell compartment to call them adequate, for analysis. So why we made that rule, just like yesterday we discussed whether it should be 300 or 500, because, if you think you want to see 20 cells in one cluster because most of them identified in the C34 immature cell compartment, you have to, to reach 0.1% sensitivity, you have to have at least 200 cells, immature cells, for analysis. But as I said, like a positive does not stop you, to call, with less events. Positive is positive. You can say positive in a limited sample, that will affect your quantification, but the positive is positive.
Okay. I think we have come to the end of this wonderful session. Thank you so much, Dr. Wang, for giving us your time and for this wonderful presentation and the discussion. And I'd like to thank all of you who have joined on evening time and be with us in this discussion. I'll also like to thank MCure for giving us this platform and making this webinar possibility without any glitches. A very good evening to everyone, and thank you, ma'am. Thank you so much.
Sure. Thank you.